So let's move on to the talk. The title of which is Measuring Quality in Healthcare. It's 12 midnight here, so kung makatulog ako, pasensya na. But I'm gonna start off with a personal story that motivated me to be interested in quality. And this happened in 2002. It was July 31st, and I sustained a mountain biking injury with a right lower leg fracture. So I was admitted on a Wednesday, and this was in July. So for those who don't know, July is the month where you have new interns starting. My surgery was scheduled the following Friday, and it was supposed to be the first case. And my orthopedic surgeon assured me that it was a straightforward case. At that time, I was running marathons, and he said that I'd be training in no time. So Friday came, that was August 2nd, and unfortunately, there were a lot of trauma cases, and my operation was pushed to a later time. So the surgery didn't start until 3 o'clock. It was a 3 hour surgery, and it finished at around 6 p.m. I was transferred to the regular floor, and everything seemed fine. But at 1 o'clock in the morning, I woke up with some pain, called the nurse, and I was given some morphine. But the pain wasn't going away. So at 2 o'clock, around 2 o'clock, an hour later, I asked to see the nurse and actually requested to see the intern or the resident. But it turned out that it was a very busy night. So the intern was scrubbed in the operating room. So I said maybe I could see the resident or the chief resident, but they were all in the operating room. So the pain wasn't going away. It was getting worse. They kept instructing the nurse just to give me morphine. And at about 6 a.m., the pain was unbearable, and I was actually at the point of leaving against medical advice. I called my boss, who at that time was the SICU director, requesting him to transfer me to another hospital. But he knew the chief medical officer of the hospital I was admitted to, and the chief medical officer contacted my orthopedic surgeon right away, and in like 15 minutes, he was there. So by the time he got there, the pain was excruciating, and I was rushed to the operating room. I have lost my lateral compartment, so all the muscles were dead, and there was so much swelling so that they couldn't close my leg. And instead of one surgery, I ended up having 6 surgeries. I actually developed a Pseudomonas osteomyelitis, or infection of the bone. And it became a long process instead of the promised, this is going to be a quick and simple surgery. But I still considered myself lucky that I didn't lose my leg. If I didn't have any connections, then I'm probably one of those who would have gotten his leg amputated. But it made me really appreciate being a patient. After the incident, I spoke to the nurse, I spoke to the residents, and everyone obviously was apologetic, and it's not like they were lazy or incompetent. I'm gonna start off with every system is to produce that many the organizations that crafted that definition. Here, improvement. Okay, so the IHI used 6 adjectives to describe what quality in healthcare is supposed to be. The very first adjective is safe. Effective is the second one, and we will be focusing on that particular adjective later on. The third one is patient-centered. Healthcare is also supposed to be timely, efficient, and equitable. In layman's terms, that means that there should be no needless deaths, no needless pain or suffering, no unwanted waits, no helplessness, and no waste. Some of you may have seen this graph in the past, and it shows how healthcare relates to other types of industries when it comes to safety. So on the right-hand side of the graph, you would see industries that are considered to be ultra safe. So less than one complication for every 100,000 opportunities for error. And you could see this airline industry is there, particularly referring to airlines in Western countries. European railroads is also there, as well as nuclear power plant industry. On the left-hand side are industries that are considered dangerous, where you see more than one error for every 1,000 opportunities for error. And together with mountain climbing, you would see healthcare. Okay. I keep losing the control of my... So the experts in quality are saying that if the airline industry tolerated the error rate that healthcare industry does, there would be about 3 jumbo jet crashes every 2 days. These are the number of people who die from preventable errors in healthcare. Healthcare is unsafe. The first reason is that there tends to be a lack of awareness. And most of the time, rather than assuming that we are humans and we will commit errors. Okay, so as I have stated earlier in my in the anecdote that I had shared, medical errors are committed by competent caring people doing what other competent caring people would do. And to quote, quality problems occur not because of a failure of goodwill, knowledge, effort, or resources devoted to healthcare, but because of fundamental shortcomings in the way care is organized. There was a lot of pushback at the beginning of the quality improvement movement, at least here in the United States. They kept saying that healthcare is so much more complicated. For example, anesthesia, which is considered the safest of all the different specialties, there is about 1 death for every 200,000 cases, and that's so much less now compared to what anesthesia used to be in the 1960s and in the 1970s. But even 1 death per 200,000 cases is still 25 times more dangerous than flying. But the people who push back against quality improvement would keep saying that healthcare is so much more common, 155,000 possible. But I would argue, and yet they are the analytical consideration of how to achieve the best results to get the job done. And we keep every day, but we make little headway in making things better. What are the barriers to quality? There are poor physical quality. But I would argue that quality is even more relevant in resource allocation and use. And resource without improvement will only buy the same failed processes, and this is a very expensive process. In low and middle income countries. There are very few studies, unfortunately. The first study actually came out just 3 years ago. This was in the British Medical Journal looking at safety, so not even quality, just patient safety. And what they did was to review medical records from 8 countries. And these are the most common reasons that they found as the sources of complications. therapeutic error, mistakes in diagnosis, operative error. So the same thing that we see here in the Western world where they operate on the wrong leg or the wrong side of the brain. A lot of obstetric um, preventable errors as well as neonatal errors. When they ask the experts, what do you think are the ways to reduce these errors? People always assume that improving the resources would be key in reducing complications in the healthcare setting. But when the experts compiled what they think are the remedy for these problems, resources is there, but it's not up there. It was the fifth in terms of the ways to curtail some of these problems. The top three recommendation is one, having protocol and treatment guidelines and really better oversight of the processes and better outcomes tracking. Continuing education was touted as possibly the second best remedy for the problems that they were seeing, and improving communication across specialties and across the different personnel. This is another study that was published in the Bulletin of the World Health Organization, and this pertains to the use and prescription of medication. So again, we assume that if we only increase the availability of medications, then we will improve the health outcomes in low and middle income countries. But this report was an eye-opener. It summarized the results of studies that were reported between 1990 and 2006. And what they found was that there's generally poor quality prescribing and poor quality of data for both public and private sectors. So it wasn't limited to the public sector. More than 50% of all medications are prescribed, dispensed, or sold inappropriately, and half of all patients fail to take the medications correctly. And that less than 30 to 40% are treated according to existing clinical guidelines. So I'm gonna go back to the Western world, and these are four of the organizations that measure quality here in the United States. We have the Consumer Report, Health Grades, the Leapfrog Group, and the US News and Health. And there was a study that was published in March of this year where they looked at the ratings of those four organizations. And this paper was authored by some of the biggest names in quality improvement, including Peter Pronovost, Ashish Shah. And what they found was that these four national rating systems frequently come to very different conclusions about which hospitals are best or worse. Some hospitals were rated in the top 10 percentile, and they found themselves in the lower 10th percentile in the other ratings of the other organizations. And it really highlighted that we still don't have a very good grasp of what quality in healthcare is supposed to be. So the last part of the talk, I will focus on some of the elements of quality, which I think we could all agree as important in healthcare. The first one is application of evidence-based interventions to individual patients every single time. The problem, of course, is that evidence-based medicine does not exist for everything that we do in healthcare. So the gold standard for evidence-based medicine is prospective randomized controlled trial. But there are a lot of flaws with the use of prospective randomized controlled trial to direct clinical practice. One, they provide an average effect. It is a population-based study. We also typically evaluate one intervention at a time in a prospective randomized controlled trial. Seldom do we try to evaluate combinations of interventions. An important issue which arises in the intensive care unit where I work is that there are lots of inclusion and exclusion criteria that would limit the external validity. For example, for ICU studies, we typically would exclude patients older than 75 years old. At least here in the United States, a significant fraction of our patients are greater than 75 years old. So what are we supposed to do when we're taking care of these patients? A more important reason or flaw of evidence-based medicine as it exists now is that there are lots of errors and biases that abound in the medical literature. a landmark study that came from John Unitas, where he looked at the most cited original clinical research of the previous century, found that a third of them were later refuted. So this is a paper that was published a couple of years ago, and this is looking at one journal, so the New England Medical Journal of Medicine, and it's one of the highest impact journal. And what the authors did was just to review over a decade some of the standards of practice that were evaluated. And what they found is that out of 363 articles that tested the standard of care, there were more articles that actually concluded that the standard of care turned out to be not the best possible option in terms of providing the best outcome, and later turned into reversal of that practice. In an accompanying editorial of that paper, John Unitas wrote, and he entitled his editorial as "How Many Contemporary Medical Practices Are Worse Than Doing Nothing or Doing Less?" And I quote in his editorial, he said, "Half of what we know might be wrong and the other half useless." These are some of the other problems with evidence-based medicine. An analysis of more than 1,000 Cochrane systematic reviews found that in almost half of them, after looking at all the evidence to evaluate a certain intervention, they concluded that the current evidence does not support either benefit or harm, and their recommendation in 96% of their systematic reviews is that additional research is recommended before we could really say whether an intervention is beneficial or harmful. And on top of that, most of what we do as clinicians has never been formally put to the test. So measuring effective care is limited to few diagnoses and are narrow in scope. For example, here in the United States, we measure how effective our care is for acute coronary syndrome by measuring the time from door to balloon, or we measure how effective our care is for septic patients by looking at the time to antibiotics, as well as the time to, as well as early fluid resuscitation. But that's a minute fraction of the interventions that we do. The rest of the interventions are not really appraised in terms of how effective they are. The second element of quality is really the service part. This is what the patient sees. And this refers to compassion, good patient-provider communication, and shared decision-making. In the US, we use patient satisfaction surveys to evaluate the service component of quality. But it turned out that this is not as straightforward as we think. There was a landmark paper that came out of the University of California, Davis investigators, where they found that the most satisfied patients were also more likely to use more prescription drugs, get more hospitalized even after adjustment for their severity of illness, and are more likely to die. So the take-home message of that paper is that the patient's perception of quality is colored by whether or not their expectations were met. And finally, what I think and what most experts think as the most important element of quality is this teamwork and culture of quality. This is a bit invisible to the patient. They don't really see or appreciate or understand the amount of teamwork that needs to happen in the ICU, in the emergency room, in the operating room. There is really no appreciation of what a culture of quality is, and that pertains to every personnel in the healthcare organization, whether they're providers or not providers, and whether they feel empowered to contribute to making sure that they're constantly improving the way they deliver care. And at present, there is really no tool to measure teamwork and the culture of quality that could be routinely used to measure that component of quality. So the holy grail, really, what we are trying to design here, at least in our laboratory, is a digital quality system where we could track all the components of quality continuously and in real time, versus what we do now, where we create episodic retrospective reports, which are a bit too late because most of the time the poor quality has already happened and there's nothing that you could do about that. And what you would like for this system to do is to provide actionable items at the point of care. So I'm going to end my talk there. I just wanted to have to acknowledge some of the people that help me with the work that I do, the MIT Lab of Computational Physiology, some of the professors that I work with. I work with a lot of Core 6 students from MIT and Institute of Biomedical Engineering students from Oxford, as well as residents, fellows, nurses, and pharmacists at the Beth Israel Deaconess Medical Center. And over to you, Yela.